Good morning. Welcome to the Norman Education Research Day for 2026. It's my pleasure to welcome you all to engage with our learning community today. My name is Lawrence Gerson. I'm the Assistant Dean for the Health Science Education Graduate Program. For those of you who don't know, HSED, or the Health Science Education Graduate Program, is a professional master's degree training program for clinical educators, for working health professionals who find themselves faced with the challenges of the education sector. This event, while it's a faculty-wide event, is a real anchor point and hallmark for our students who are starting the program and leaving the program as part of their residency week. So can I just, for the sake of it, can I see a show of hands of folks who are HSED students currently? Keep them up. Who was previously a HSED student? Well, everybody. I'm trying to get the whole room to put their hands up. Yeah, we have a great tradition over 10 years now of matriculating students into a number of education leadership roles, into high quality training and education for clinical spaces. Folks like Sam Jarman and Nita Kai. They're scattered throughout the room, so hopefully you have a chance to, if you're not an HSED student, you have a chance to be one. That's an important thing, but to talk with folks along the way. It's important that we start the meeting with a land acknowledgement. So McMaster University is located on the traditional territories of the Haudenosaunee and Anishinaabe people. It is land covered by the Upper Canada Treaties and adjacent to the Haldeman Treaty territory. And it's covered by the Dish with One Spoon Wampum Agreement. And as I said on Monday, Stephanie is always on me on making sure that we don't just repeat the land acknowledgement, that we take the idea of the reflection of the meaning of making social change into our practice as educators. We were very fortunate yesterday to have Lori Gallant, who's an Indigenous art educator, speak to our students about the way that our colonial institutions have the power to exclude stories, and in doing so, to remove people from our histories, and in particular the Indigenous peoples of Canada. She was also able to draw our attention to the transformative power of education systems. And when we think about the residential school, we can see that transformative power is not always positive. It oftentimes can be very damaging, very negative. So we have to, in our work as educators, really think about how we engage with students, how we think about the space that we're taking up, the people that we might be excluding from the professions that we're training folks into, and in our society overall. We're glad to be able to extend these ideas of thinking about the positive transformative power of education today with a keynote discussion on inclusion in the disability space for education today. And I think in this we can see how these ideas of carrying the reflection forward into our practice can influence change. So I'm going to invite you to join us through all of the sessions today and to think about these ideas. We call today Nerd because we're nerds. Because we really think deeply about education science, and we geek out about it, and we sit around and have these like long boring talks, and if you do it at the dinner table with your family, they ask you like 5 seconds after, like, why did I ask you what your thesis is? But here, this is a space for us to really get deep into these. That's only one of the reasons why we call it Nerd. The other reason is because it's an acronym, and it stands for Norman Education Research Day. And the Norman in question is Dr. Jeffrey Norman, who is a real trailblazer for the field. He just talked about, just introducing to Cheryl, our keynote, earlier this morning. He said, I started with George Bardage back in 1977. I started my bachelor's degree. That's the year I was born. And now I'm going to say old I am. So he's been at this for a really long time and made numerous really important contributions to the areas admissions, the list is very, very long. More or less, if you're from the McMaster community, he's a house on fire. So, if you're from the McMaster community, you really don't need me to be giving you this introduction. So I'm just going to step aside, and I'm going to invite Jeff forward. He's got a few words for you all, and he's going to introduce for you our Health Professions Education Award winner from last year to say some words as well. So, Jeff.
I didn't know when I heard that siren whether I was supposed to clutch my chest or what. It's great to be here. It's great to have all of you here. It's been a while to vet this, and I kind of like everything, truth be known. I'm here with this very briefly this morning to introduce Ruth Chen, who was our Health Professions Education Educator Award last year. Ruth and I go back a long way, which may surprise you because she's so youthful and I'm so ancient, but let's just say I'm younger than I look. Okay. I tried to memorize, in particular, I started looking at our past mutual history yesterday and went back to when she was getting her PhD with me about 12 years ago, I think, more or less. They were really neat studies, I have to say. And what I really liked was a study where she was looking at high fidelity versus low fidelity simulation, which was and probably still is a big deal. And what she showed was counterintuitive, that in fact, there was no advantage to high fidelity at all, but under some circumstances, low fidelity simulation of auscultation actually gave better results than high fidelity. It's a nice example of how educational research can be applied to very, very practical problems. In that case, saving a heck of a lot of money because you don't have to buy multi-$1,000 simulators to teach people how to listen to art sounds. So that was a great pleasure. Of course, being her supervisor meant I had to do very little work. She did it all. I tried to memorize all what she's been doing since yesterday I sat down, and after a couple of hours of trying to memorize it, I just gave up. So I'll have to skip through the text. Right now, she's the Associate Dean in Continuing Professional Development in Faculty of Health Sciences, Associate Professor in the School of Nursing. She's also Acting Director of the McMaster Continuing Education Program, Pathophysiology course lead for the Provincial Primary Health Care Nurse Practitioner Program. Teaches in undergraduate programs, graduate programs, taught in the HSAD program in Florence. She's also been the Assistant Dean of Academic Resources, the DEC for the School of Nursing, and Assistant Dean of Faculty Development. Somewhere in there she manages the street vacation. I'm delighted to introduce you briefly to Ruth Chen.
Thank you for that. And it's very interesting to hear Jeff's perspective on my time as a PhD student, because I would say I was probably one of his worst students. And I have many, many, many examples to support that statement. But, you know, at the end of the day, I realized that I have no business being here welcoming all of you nerdies to this conference. My biggest claim to fame is that I was just a PhD student. And I have to say, when I was thinking about the fact that, 13 years ago I defended this PhD, and I could probably give a full workshop on what not to do and all the mistakes that I made along the way to get to that PhD. I survived, and I've realized that over the past decade and a half, or the 2 decades that I've known Jeff, he has built the foundation of what I know of education research. I mean, it is literally, I'm not being hyperbolic here. I still think of comments that he's made, stories that he's told me, rants that he has. If you have not had a chance to listen to one of Jeff's rants, you are missing out on a real special privilege. And so these form the basis of my education research understanding, how I proceed in curriculum development, leadership, even in some of these governance meetings that I attend, and I can hear Jeff's voice coming back to me. And so, yes, I recognize I don't have any individual contributions that I can provide to this education science crowd. And yet, when I was asked to provide the opening remarks, I gladly said yes. Because even as I think about the way that I'm pulled in so many different directions these days, that I can probably say, well, my greatest skill is being a university bureaucrat. I think about nerd. I think about the programs that are offered at Med and the collaborations there. I think about the HSCD program. And I think, these are my people. This is where I belong. You are my people, even if I don't know you. And so I thought of that, and I realized that what I appreciate most about being here is that I can simply be. I can be open to learning. I can be ignorant and have you teach me and share your expertise and insight and lived experience, and I can be changed. I can be wrong. I've been wrong many times, and I love it when I'm wrong, actually. And Jeff corrects me, or others in this community show me that, oh, the evidence is actually showing this, or the lived experience is leaning in this direction, and I can be corrected. And in this community, I can also be curious, and I can ask questions. I can engage in conversations around those wicked questions, or even the not wicked questions, but that are just interesting to our education research community. And so my welcome to all of you is that I hope that you will find Nerd a place where you know you belong, and a place you know that you can be enriched in your mind through the conversations, and that hopefully your soul can also be enlivened through the discussions and the interactions and the community here. Because there are really great people in the community. And as I'm talking, I'm like looking around and like giving eye contact to people because you know who you are. You are brilliant. You are inspiring. And you are what makes this community so rich. And this is a community that I love belonging to. And I hope that you will have that same experience. So welcome. Have a great day today.
Thank you, Dr. Chen. I feel like I need to wear my hat. At the end of the day, so it might have gone missed there, but Ruth is the 2025-2026 Health Professions Educator of the Year Award for Faculty of Health Sciences, which is what leads her to come up here. It's obviously an enormous honor. At the end of the day today, you'll have the opportunity to hear the announcement of the 26-27 winners, so please stick around for that, and we'll be able to celebrate more of our education here. It's my pleasure to welcome Dr. Cheryl Holmes to McMaster University. I've got a long list of her accolades and activities to read out with you. But Cheryl will be our keynote speaker today. So Dr. Holmes serves as the Dean of the Ross University School of Medicine. She's a clinical professor and the former head of critical care and Associate Dean of Undergraduate Medical Education at the University of British Columbia. Dr. Holmes is committed to fostering respectful, compassionate, and health-promoting environments in academic medicine, where excellence is strengthened by equity, decolonization, diversity, inclusion, accessibility, belonging, and social justice. Dr. Holmes' academic interests include promoting learner well-being, fostering inclusive and accessible learning environments, social accountability of medical schools, and facilitating the professional identity formation of health professionals. She is the recipient of the University of Illinois Chicago's MHPE Program's 2013 Best Thesis Award for her thesis entitled Harnessing the Hidden Curriculum in Clinical Clerkship, a four-step reflective competency approach. In 2015, she received the Canadian Association for Medical Education Certificate of Merit for her outstanding contributions. Her keynote today will examine the evolving landscape of technical standards and disability inclusion in medical education, exploring philosophical foundations, accreditation implications, and the tensions they generate. It foregrounds humility, emphasizing the ongoing unlearning of assumptions about disability, merit, and excellence, and the need to recognize how ableism operates within education systems. Addressing persistent pushback, underreporting, and the gap between rhetoric and practice, it considers implications for new schools and transitions to postgraduate training. No further ado, I'll pass over the microphone to Dr. Holmes.
Thank you so much for that warm welcome. And I have to say that I feel at my best when I'm in the company of educators and scholarly educators. So like the person before me, this is where I feel I can be fully me. And so thank you for that opening. That was really beautiful. Before we begin, I want to acknowledge my own positionality. I speak today as a physician, an educator, and a dean, but not someone living with a permanent disability. My understanding, though, has been shaped by family experiences, my own temporary episodes of disability, and most importantly, by learners, physicians, advocates, and scholars who have shared generously their lived experience and expertise with me. And so I'm still somebody who's learning and unlearning, still wrestling with the tensions. And because this conversation today is not about accommodations, it's about who we unintentionally exclude in the health professions, how we define merit, how we define competence, and ultimately how we define the health professional of the future. And so the symbol that I'm presenting here for transformation of health professional culture is the Kintsugi vase. It conveys that medicine itself needed to change, and that those changes can make it more beautiful and stronger than before. So I have no competing industry interest to disclose. There's going to be some audience participation. So I'd like you to take out your phones and log into ttpoll.com. The session is Equity 2026. You just have to press join. You don't have to put in your name, your email address, your firstborn's name, the name of your dog, anything like that. You just press join, and then you'll be in the poll. And I would also like to do my land acknowledgement that we're gathered on the traditional territories of the Mississauga and Haudenosaunee nations protected by the Dishwood-Wanspoon Wampum Agreement. As a visitor, I'm grateful to be here. And the themes of today's talk, listening, inclusion, belonging, questioning assumptions, are deeply connected to the spirit of acknowledgement. The work of accessibility begins with humility. It begins with recognizing that our own perspectives are incomplete. And for me, that lesson began long before I entered medicine. So I'm going to dedicate this presentation to my Uncle Eugene Reimer. As a child, Uncle Eugene contracted polio that left him without the use of or very limited use of his legs. And at a time in the 50s, and 40s and 50s, when many assumed that life with a disability would be limited, he refused to let others define what was possible. He became a draftsman, a building contractor, and an extraordinary athlete. Over the course of his athletic career, he won over 50 medals and 22 international medals, including 10 Paralympic medals. His first Paralympic Games in Israel, he won 2 gold medals and a silver. And in Germany, he captured gold medals in the discus and pentathlon. And his impact reached far beyond the medals he won. In '72, he became the first athlete with a disability to be named Canada's Outstanding Male Athlete of the Year. And 2 years later, he became the first person with a disability to receive the Order of Canada. And his legacy continues through a middle school named after him in my hometown, Abbotsford, and the Eugene Reimer Award, which is established by the Terry Fox Foundation. Yet, despite decades of progress in diversity and inclusion in our society, disability remains one of the least visible dimensions of diversity in the health professions. Many of us are familiar with the concept of equality, the idea that everyone should be treated the same. But equity asks a different question. Rather than giving everyone the same thing, it asks, what does each person need to achieve meaningful success? For many years in medical education, our systems were designed around equality. We held everyone to the same processes, the same environments, the same assumptions about what a learner must do. And the challenge before us is moving beyond equality towards equity and towards inclusion. So the next step in our thinking is not just about providing accommodations, it's about designing learning environments, assessments and technical standards so that barriers are removed from the outset. That shift from accommodation to accessibility, from retrofitting to equity by design. The question is not simply why disability remains underrepresented. The deeper question is why medicine continues to struggle to imagine disability as compatible with professional excellence. And to answer that question, we need to talk about ableism. So I want you to go to your poll, and I want you to pick which statement best describes ableism. Yeah?
I'm not seeing anything.
Yeah.
Oh.
I see a lovely beach.
Yes.
Oh, okay. I have to start it again. Okay, let me just, okay, now it should be okay. Thank you for that.
I tested it out earlier, and so that I had closed the pool.
Everybody in now? Everyone pick their choice? Okay, let's see what we have to say. All right, if you answered C, you are correct. Ableism is not simply prejudice against people with disabilities. It's the assumption that there is one normal way to learn, to communicate, to move, to examine patients, or to practice healthcare. And that anyone who differs from that norm is somehow less capable. Once we begin to recognize ableism as a system rather than an individual attitude, we can start asking a different question. How have our institutions defined who belongs in healthcare? So let's examine one of those places where these assumptions become most visible, and those are the technical standards for admission to healthcare programs. For many years, the CACM standards shaped how medical schools defined who could enter medicine and who was capable of being a physician. Under previous CACM standards, schools were required to publish technical standards describing the cognitive, communication, sensory, motor, and social abilities expected of learners. The challenge was not the existence of the standards, but how they were interpreted. Many focused on whether a student could hear, speak, or perform a task, rather than whether that task could be completed safely or effectively using accommodations, adaptive strategies, or assistive technologies. And this raises an important question. Do all healthcare individuals need to perform tasks in exactly the same way, or should we focus on the outcomes that they achieve? So let's consider one that often sparks a lot of debate. So I want you to go back to your poll, and you see this one here? And I want you to answer A, B, C, or D. Okay, everyone done? Let's see what people said. Medical schools, and 73% used language that could be considered discriminatory towards learners with disabilities, and only 13% explicitly mentioned accommodations. So even as new schools emerge, diversity and inclusion, many are continuing to send message that learners may not belong. The challenge isn't simply building new schools, it's ensuring that we don't recreate old barriers. And these aren't isolated examples. Many of the language still found in our technical standards can be traced back to the AAMC special panel on technical standards from 1979. So I want you to look at this example. This is in almost all of the technical standards in the US and Canada, the behavioral and social attributes section. And as you read it, now think about which phrase concerns you the most. And then I'm going to ask you to vote. So, necessary traits of a student. That's interesting. Most people pick the same one. All these statements sound reasonable until you ask how they would be assessed. They're broad, subjective, and they often tell us more about the culture of medicine than the competencies required to practice it. And more importantly, are these truly competencies required for the practice of medicine, or are they reflections of a training culture that we have normalized over time? To address these limitations and to facilitate increased disability representation among medical students, we formed a working group to re-envision the technical standards as functional competencies. So it just kind of grew organically at a meeting between the undergrad deans and the student affairs deans, and I asked, we're going to change these at UBC. How many would like to go on this journey with me? And 5 people put up their hand. And these were the people that eventually joined the working group. Our first principle was representation. So we embraced the disability rights principle of nothing about us without us. What began as a group of 5 volunteers grew to 18 members, including physicians, medical educators, accreditation leaders, disability scholars, legal experts, patient partners, and medical learners. Importantly, half of the working group identifies disabled or living with a disability, ensuring that we were able to capture that lived experience, and it was central to the conversation rather than an afterthought. As we considered representation, one voice was very important, Dr. Julia Haynes. So she's a practicing physician, Paralympian, and record-setting Canadian track and field athlete who has lived with a physical disability throughout her education and medical training. And her lived experience has challenged many of our assumptions about disability and competence. And she reminded us that our technical standards should focus on outcomes and not methods. And that qualities such as adaptability, creativity, problem solving, and teamwork are all central to excellence in medical practice. So her perspective led us to our first question, which was which lens should guide this work? And there were 2 lenses. One was the human rights approach. This is the law. We have a duty to accommodate. And the other one is the broader cultural issue that causes us to rethink how medicine understands disability and belonging. And we decided to embrace both. And that discussion changed everything, shaped everything that followed after that. So I'll start with the human rights approach. And this is the Jessica Dunkley versus UBC case. She was one of the first deaf physicians to practice in Canada. And she requested American Sign Language translators during her residency training and was denied because of undue hardship. She challenged the decision through the BC Human Rights Tribunal, and it ruled in her favor, finding that the university and the health authority had failed in their duty to accommodate. The case was appealed, and under the Supreme Court, they dismissed the appeal, and this became a landmark Canadian decision in medical education and disability rights. This case highlighted important shift in thinking from accommodating individuals after barriers arrive to preventing barriers in the first place. And that shift was reflected in the Accessible Canada Act passed in 2019. So that was, the goal was creating a barrier-free Canada by 2040. So the Act moves us beyond accommodation towards proactive identification, removal, and prevention of barriers, a principle with important implications for health professional education. Rather than waiting for an individual to disclose a disability and request support, organizations are expected to identify and remove barriers before they become obstacles. And that is truly the essence of equity by design. Now, the duty to accommodate sounds straightforward in principle, but I'd like to hear your emotional reaction when you hear the word accommodation. And I'm so glad this is working. This is the first time I've tried this in a real environment, so. Okay. Let's look at the range of responses in the room. Yeah. Good. Opportunity. That's cool. Complexity is the next biggest, and is the next biggest one is uncertainty. Yeah. I think what's striking is the range of reactions in the room. For some, accommodation represents fairness and opportunity. For others, it raises concerns about complexity, burden, or uncertainty. And the goal here isn't to judge those reactions, but to acknowledge them. They reflect the tensions that have shaped the discussions about disability and medical education for decades. Because how we feel about accommodations often shapes how we respond to learners who are requesting them. And with that in mind, let's look at what accommodations in health professional education actually involve. One persistent myth is that accommodations lower standards, and they do not. Accommodations change how competence is demonstrated, not what is being assessed. The goal is not advantage, it's equity. The learner remains responsible for clinical reasoning, decision-making, communication, and patient care. The standard stays the same. The pathway may look different. In many ways, this is how healthcare already works. We use technology, teamwork, interpreters, consultants, and others to help us provide excellent care. Accommodations simply recognize that there can be more than one path to excellence. And we often talk about accommodations as if there's something unusual. This is my story. I was a critical care physician, and one of the nurses in our ICU took a photo for me of my last procedure in the ICU, which is very special. And like many critical care physicians, I prided myself on being capable, independent, adaptable. I worked very long hours, managed very complex patients, and rarely questioned whether I could meet the physical demands of the profession. And then unexpectedly, I came down with brachial neuritis, and to make a very long story short, the only thing I was not able to do was this, which is what? Intubate. I could no longer intubate conventionally. So I stepped away from clinical practice for about, I think, 4 months, and I began learning to use a relatively new technology at the time. I tried many different things. The glide scope, invented incidentally by a surgeon, inventor friend of mine, Dr. Jack Casey. And he was a vascular surgeon, and he was tired of watching people trying to intubate with a conventional laryngoscope, so he invented the glide scope. And so I learned how to use that. And at the time, I didn't think of myself as a person with a disability requiring accommodation. I simply thought I was adapting to a problem. It was only years later that I came to see this differently, that the glide scope had become my accommodation. And what initially felt like a limitation became my go-to. My workaround soon became my preferred approach. I improved It improved my management of difficult airway patients, enhanced patient safety, and became a valuable teaching tool for residents and colleagues in the ICU. And it became my new normal. So the GlideScope didn't eliminate my impairment, it removed a barrier. And that's the insight and the broader shift in how we understand disability today. Rather than viewing disability as a limitation of an individual, the World Health Organization defines disability as the interaction between the person and the barriers they encounter in their environment. In other words, disability is not a characteristic of the individuals. It's a product of the systems and environments in which people live, learn, and work. And the distinction is profound. It shifts. Now this is telling me that I'm going too slow. So, if disability arises from the interaction between the person and their environment, then the responsibility for inclusion can't rest solely with the individual. It's the shared responsibility of institutions, educators, workplaces, and society. And this is the basis of the disability affirming approach, which was the other lens that we wanted to center our work on. I've spoken about my Uncle Eugene's Paralympic achievements and national recognition, but I'll tell you about something that most people don't know. Every Thursday afternoon, he would take time off his work from being a draftsman and a contractor. He would drive to Vancouver, which is 80 kilometers away. He would visit Jeff Strong, the spinal cord the rehab center, and he would meet people with new spinal cord injuries and introduce them to life after spinal cord injury and to wheelchair sports. One of the young women he visited and influenced went on to become a medical student in the year ahead of me in medical school, and she's a family doctor practicing in Topino now. One of the young men that he visited was Rick Hansen. Rick had sustained spinal cord injury at the age of 15 in 1973 when he first met my Uncle Eugene, who encouraged him to get involved in wheelchair sports. Rick actually came and spoke at my Uncle Eugene's funeral, and he said, playing for the Vancouver Cable Cars, which was the wheelchair basketball team, was terrifying the first time he was on the court. He said, they rammed into me, threw me out of my chair. It was the first time they'd ever been thrown out of my chair. I had to figure out how to get back on and continue on with the game. But Rick went on to wheel through the Man in Motion World Tour, 40,000 kilometers in 34 countries, raising $26 million for spinal cord research. And through the Rick Hansen Foundation, he shifted the conversation from disability as a limitation to accessibility, inclusion, and human potential. At its core, the foundation is guided by a simple but powerful vision that people with disabilities should be able to live to their full potential in an accessible and inclusive world. But many disabilities are not visible. As we know, conditions such as autism, ADHD, learning disabilities, mental health conditions, and chronic illnesses are common among learners and physicians, yet many individuals choose not to disclose because of concerns of stigma or career implications. So a disability affirming perspective asks the question, what strengths might we be overlooking? And Dr. Rashid, a pathologist diagnosed with autism late in her career, described the diagnosis as helping her better understand her place in medicine. And her story reminds us that neurodiversity can bring strengths such as pattern recognition, direct communication, strong ethics, and deep expertise. And so rather than viewing disability through the lens of accommodation, we can recognize how diverse ways of thinking and learning can enrich our profession. So this led us to the question, what would medical education look like if it were designed from the outset to include people with disabilities? While technical standards were an important part of our conversation, we quickly realized that meaningful inclusion would require more than rewriting the document. And we were able to get, at that time, all 17 deans of the medical schools of Canada to agree to creating a cultural shift, to ensuring accessible admissions processes, adopting a functional ability-based approach, providing institutional expertise and support, improving support across the continuum for medical school practice, and embedding disability inclusion as part of a medical school's commitment to social accountability. So this is, the common theme is shifting the responsibility from the individual learner to the institution. So our recommendations reflected where we hope education to go. But if we wanted real change to occur, inspiration alone was not enough. We needed to answer the questions deans, policymakers, admission leaders, and accreditation bodies were asking. What are our legal obligations? So one of the, for that, was a comprehensive review of the legal obligations of the Faculty of Medicine. It was conducted by one of our medical students at UBC that I supervised, and it was summarized by my daughter, who's a lawyer with a disability, and reviewed by our legal counsel. And this provided the foundation for moving the conversation beyond values and aspirations towards policy, practice, and institutional actions. So the goal is simply not accommodation, it's accessibility by design. Interestingly, the CACMS was not particularly difficult because we partnered with them from the start. So we were able to get a change from technical standards to 10.5 core competencies for entering medical students. So revising the accreditation standard was important, and it led to the next question for the working group. So what are those functional competencies? What are we changing to? And so that was the bulk of the work that we conducted. The answer was not to eliminate or expectations or lower standards, but was to articulate a set of functional core competencies that focus on what learners must be able to do to achieve rather than prescribing a simple way of achieving it. As we look through these examples, pay attention to how the language has shifted from describing people to describing functions. The emphasis is not the how, specific physical, sensory, or cognitive attributes. In fact, instead the focus is on the what learners must achieve. Learning, how learners are going to be assessed, communication, knowledge integration, and participation in patient care, with or without reasonable accommodation. So the shift is subtle, but it's profound in how we think about disability and access. This brings us back to the CPR question that we started with. Many of us instinctively equate patient safety with the ability to personally perform a specific task. Yet, we frame these competencies in patient safety much more broadly. Notice how the language reflects that reality. The focus is on contributing effectively to patient care and patient safety, not on demonstrating particular physical ability in a particular way. And notice how the difference in professionalism is framed here. Earlier, I alerted you to the historical technical standards that refer to personal or behavioral traits, qualities such as emotional stability, resilience, good judgment, or the ability to function under stress. And those descriptions can be highly subjective and may unintentionally exclude people with disabilities. So here we frame professionalism in terms of observable responsibilities and behaviors. How we expect learners to engage in self-reflection, respect standards and colleagues, and maintain confidentiality and act within ethical and legal standards. So once again, we see the shift from describing who a learner is to describing what a learner must be able to do. On papers, these functional competencies seem straightforward. In practicing, implementing them generated significant debate. Many of the concerns we encountered were very thoughtful and well-intentioned, and they raised important questions about patient safety, fairness, professionalism, and limits of accommodation. But as we engaged with educators, regulators, clinicians across the country, it became clear that these concerns were simply not about technical standards. They reflected a deeper assumption about what a physician should look like, how a physician should function, and who belongs in medicine. And so to understand that, we need to understand the culture of medicine itself and the ableist assumptions that can be embedded. So I'm going to ask you a simple question. Have you ever come to work or school or clinical training when you were too sick, exhausted, or distressed to perform at your best? Okay, let's see what people say. I'm willing to bet that most of us answered yes. Yes, frequently, occasionally. Somebody said never. Well, I certainly showed up frequently, sick, exhausted, distressed, and I was unintentionally perpetuating the hidden curriculum of the ICU, which is show no weakness, show no fatigue, show no fear. Interestingly, it was me that was the barrier, because when I started texting people that I didn't feel well enough to come in for my shift, the guys would all go, oh yeah, I can come in, I can come in, I can come in. And then they started doing the same. So I didn't realize that I was kind of the barrier here. Many of us don't see this, before COVID, we didn't really see this as a problem. Many of us were taught that pushing through illness, exhaustion, or personal hardship is a mark of dedication, resilience, and professionalism. We celebrate the student who never misses a shift, the resident who powers through fatigue, at least in the ICU we did, and the physician who keeps working. But if we step back and examine that culture more critically, a different question emerges. Why have we created a system where so many people feel like they have no choice but to keep going? This isn't about individual decisions, it's about the values and norms that healthcare profession rewards and reinforces. The expectation that a good physician should be able to push through fatigue, illness, stress, pain, fear, personal adversity. I mean, I showed up in the ICU 10 days after I fractured my pelvis with a walker, which is crazy, but in retrospect. The expectation that a good physician does this reflects a broader ideal of the invulnerable healthcare provider, someone whose body and mind can consistently meet the demands of the profession without accommodation or support. And once that ideal becomes normalized, it shapes how we think about competence, professionalism, fitness to practice, and who ultimately belongs in medicine. At the heart of this conversation, I have learned it's about the capability imperative, the deeply held belief that the good physician should be able to overcome any obstacle through individual effort, resilience, and determination. But medicine has never been a profession of complete independence. It is a profession built on interdependence. When we broaden our understanding of capability, we see that excellence is defined not how something is accomplished, but whether it can be accomplished safely, effectively, and professionally. And that's the shift that many of the assumptions we've inherited about disability, competence, and who belongs in medicine. So before we conclude, I want you to reflect for a moment. In 1 or 2 or 3 words, what assumptions about disability, competence, or professional identity have you reconsidered during this session? So I'll give you a few minutes for that. I'm just watching to see when you're finished. So if you're checking your emails, no judgment. Lots of capability. That's really cool. So before I close, I'm just going to briefly highlight where this work is heading, because I did say in the abstract that as we talk about the continuum to PGME, which I'm not personally involved in, but these two beautiful people are. Dr. Michael Kwan, University of Ontario, a very gifted disability scholar. He is conducting a national environmental scan examining accommodations policies across postgraduate medical education programs and resident organizations. And he told me personally that early findings suggest significant variability, highlighting opportunities for greater consistency, transparency, and support. There is currently no Royal College or CFPC accreditation standards that specifically address accommodations policy. So there's an important opportunity here for system-wide improvement. And then Dr. Sonia Butterworth, PGME Dean at UBC, told me that there's national guidance emerging to support the transition from UGME to PGME, including harms considerations related to accommodations and competency achievement. Accommodation responsibility is evolving with increased collaboration between universities and health authorities. So in British Columbia, the health authorities are taking on the responsibility of managing learner accommodations. And the functional competency framework are expanding into PGME, informing entry-level expectations for residencies, subspecialty, and fellowship training. And at UBC, she has pioneered the functional competencies for entry into PGME. So really great work going on. So throughout this talk, we've discussed disability accommodations, technical standards, accreditation, and culture. But ultimately, this conversation is about belonging. The question is not who belongs, whether people with disability belong to the health professions. They already do. The question is whether our systems are designed to recognize their contributions and support their success. As educators, leaders, and researchers, that's the challenge before us. Who belongs in medicine? I believe it's everybody who can contribute to the care of others, and the rest is design. So I'm going to leave you with that thought. If you want to hear more about the work that we did, there's two podcasts that were recorded during ICAM in the Docs. If you haven't listened to Docs with Disabilities podcasts, they're great. And then the work that we did that I referenced throughout was published in Academic Medicine last September. So I'm going to stop there, and we have time for questions.
Thank you, Dr. Holmes. We do indeed have time for questions. I know that there are some plans in the audience already, folks that are prepared to ask you questions, I'm sure. So let's start with the audience. Yes.
I had a question about, so I think like the work that you're doing to revolutionize like academic training is fantastic. But knowing that medical and allied health education relies so much on academic and professional partners with organizations, how are you ensuring that the work like extends into those settings as well, so they feel as welcomed in like clinical education?
Yeah, thanks for that question. So I didn't show a slide of all the organizations that we partnered with in doing this work. We included them very early on in the consultative process. So the medical regulators, there's an organization that is all of the colleges of professional practice in Canada. We partnered with them, and it very much aligns with the direction that they're going. We talked extensively to Chris Watley at the Royal College. We talked to people at the College of Family Physicians of Canada. We didn't talk to nursing organizations, although we did have people from occupational therapy and physical therapy organizations in our group. Yeah, so just partnering with them. Really, there's strong alignment
eats strategy for breakfast every day. So there's lots of work to be done on culture, and so that's one of the reasons for giving this talk today, is to really raise awareness about the culture of health professions and ableism that permeates that culture. Yeah.
Thanks for an excellent talk. Question, have you ever come across any evidence on the patient perspective or the public's perspective on more health professionals with disabilities in practice?
Yeah, so I wish I had, not a lot, just anecdotal from the patient partners that were in our group, patient partner organizations that I've partnered with. They want to see more representation. One of the big proponents is Dr. Bonnie Sawatsky, PhD with the Department of Orthopedics at UBC. And, she has done a lot of work with patients who love to see physicians that are like them. I wish there was more published literature. Very early on in this work, I asked ChatGPT for articles in PubMed that answer that very question, and it gave me 6 very plausible articles that exactly hit what I wanted, but didn't exist. I went to bed saying to my husband, oh, my work is done. Got up in the morning, I'm like, oh no, there's a lot of work to be done here. So I wish there was, but there isn't. We really looked at that. I mean, there's indirect evidence, but not direct evidence. Yeah.
For the single partner, talking about physicians who are showing up to work safe, etc. How do you reconcile the need to create such a culture with the very hard and important fact that it's a zero-sum game? If someone's not there, or someone else has to expend themselves and be scheduled where they're supposed to be. It ultimately comes down to a zero-sum game, and that's sort of a constraints which promotes the culture, but it seems like sometimes it seems like an unsolvable problem. So you can't just create
Yeah.
workforce.
I mean, that's the world that I was in the ICU. I mean, when I started in Kelowna, we did like a week straight, Monday morning to Monday morning, except long weekends when we did Monday morning to Tuesday morning, and then we went to a system where, we had, somebody came in and did Thursday night and Friday night so that you had some sleep going into the weekend. And then we started to change things and expand things. I think, so I just thought that was just normal. And it's not. And I think we can redesign things. We created the system. We can redesign it. I mean, look at anesthesia, how that has changed, patient safety-wise. The airline industry, pilots, truckers, we can change it. And so I think the first step is recognizing that this isn't humane and it's not good for anyone. It's not good for people who are disabled. It's not good for people with families. It's not good for anybody. So, and as I said, it's surprising how simple it is. Like, honestly, I would just group chat the guys in the ICU, and they'd be 2 people would say, yeah, I can come in. So sometimes it's easier than you think it might be. I mean, I understand there's very real exceptions to this, for sure. But the other thing is, yeah, I'll belabor it. I could go on with that. Because that's the world I came from, right?
I mean, if you'd like to go on, I can put my hand up.
No, go ahead.
First of all, thank you for this presentation, your time, your research. I actually found an article yesterday, not through ChatGPT, so it is real. I did look at it was like a comparative case study of the experiences of disabled medical students in the United States and in Canada. And I think there is a UBC link somewhere, but like through, whatever, that's not the point. But I found that a lot of Canadian students, Canadian medical students experience, or at least at the undergraduate level, experience this dissonance between, you know, how accommodations are understood at undergraduate. You know, it's fairly, although problematic, it is straightforward. You know, if you need extra time or if you need an extra room, there is an understanding of how accommodations can be put in place. But when you shift to a medical school environment or a hospital environment, they don't really know what those accommodations look like. Like they don't know the transferability or the harmonization of that process is quite confusing for administrators at this current moment, or at least from the experiences of disabled medical students.
It's absolutely true, absolutely, yeah.
So I'll try and summarize, but the way that we talk about learners is obviously an incredible shift, and a disability affirming approach is amazing in terms of recognizing that disabled people can be medical students and can be competent, can perform, but how do we kind of create that knowledge to administrators beyond just, you know, like how do we allow it so that administrators are also aware of how to affirm their students when, you know, the idea of accommodation is still quite unharmonized to them at the medical school level.
Yeah. I think it's the same as how you do development, one bite at a time. I think it's one administrator at a time, honestly. It's building those personal relationships and doing that hard work of meeting with people and you know, yeah, education. And that's the work that Sonia Butterworth is doing. She's been in the trenches at UBC, you know, bridging that world with the health authorities that just don't get it or didn't get it but are starting to get it for a long time. And she's starting to make inroads. So just dogged determination and continued work. Yeah, everybody. And Michael Kwan is publishing a lot in this area too, so watch your eyes.
I just wanted to just share what I'm thinking about your question. It's definitely valid. A lot of it might also rest in just on a lower level. I mean, obviously structural organizational changes are needed, being done, but on the day-to-day, in terms of how preceptors, the supervisors, the program faculty are managing accommodation, and that sets the culture a lot in the positions. Supervisors are the ones that have power in that kind of environment, so faculty development might be important.
I think you're absolutely right. At the medical school level, where we do have some control, you know, absolutely. And when we were doing this work, you know, we were communicating with health profession regulators and college and Royal College and CACS. But when I was talking to people in my own institution, people were all over the map on this stuff. So we held a faculty development day and brought in legal counsel to talk about it, brought in Lisa Meeks from Docs with Disabilities. We also had a panel discussion. Julia Haynes was on the panel, and you know, telling her story. And I think that the most powerful stories of the day were the disabled learners telling their stories. And it was amazing. We had 200 people in the room, and in that day, everybody came to the same level of understanding of accommodations isn't just nice to do it, it's not a pain in the ass. We have to do it, we can do it, we will do it, and let's all partner together with the learner in doing it, because they know what they can do better than we do. Like Julia Haynes says, you know, people say, well, how can you talk? She has no use of her legs, and she's using one hand. She went to medical school and residency. She's a rehab physician now. And she said people didn't understand how I could do a one-handed surgical tie, but they probably can't put their hair up in a ponytail with one hand either. So, you know.
We're going to wrap up the session. Cheryl, was there a question that you hoped to be asked that you weren't asked that you'd like to speak to before we close? Did you have final remarks?
Yeah, I
was what next steps for us and where this work is going. And we talked about PGME. We're going to evaluate what we're doing. So all the deans said yes to this. Functional competencies are out there. The package has changed. The application is done. How many medical schools are really adopting this disability accessibility approach? How many of the technical standards are changing? So we've got some people working on that, and it was a poster at ICANN by one of my medical students who's doing the evaluation piece, and he's going to pilot the tool. So if McMaster would like to be part of the pilot, I'm here to invite him to do that.
Well, folks, one more round of applause for Dr. We're going to move forward with the agenda. We're going to lead into your break here, but we're going to ask you to come into the next session starting on time at 10:30, so we'll be quick in this break here. At lunch, you have the opportunity to attend to the posters, which will be presented. But in the two classrooms, will also be drop-in sessions for mixed methods research or working with secondary values. So enjoy the rest of your day, and we'll gather here